Okay, so we're going to pick up with the second video on hyponatremia. We already talked about hyper, which is too much. And this one, where hyper is going to be over 135. This one's, or I'm sorry, 145. It's 135 to 145. This one's going to be under 135. And the causes, now we don't have enough sodium in the blood. We have water loss or sodium loss. GI losses, which is usually going to be NG suctioning, nasal gastric tube, diarrhea, vomiting. In other words, all of the water is leaving. Kidney disease, psychiatric behavior of excessive intake of water. That does happen where it's more of a compulsive behavior. Diuresis or profuse sweating, and congestive heart failure. Manifestations, what did the person look like? Water excess, rapid weight gain, sodium loss, again, can cause neuroirritability. Blood pressure can be normal at first with a hypostatic blood pressure, meaning low. Very thready pulse, very fast and thready. Reduced central venous pressure. Respirations will increase as hypoxia continues. Important point, I stressed it before, is that sodium and water are always connected. Congestive heart failure, what is that? The blood is not pumping enough or fast enough to get rid of excess fluid to get to the kidneys, so it's retained, and it goes all over the place where the people have a very hard time breathing. So the treatment for hyponatremia, and again, that sodium less than 135, we're going to restrict the fluids and maybe give them a hypertonic solution. They need maybe 3% sodium chloride because we need to get some sodium in the blood. Treatment of sodium losses, we've got to slow the loss of the NG suction. Maybe they still have the NG tube, but we're going to lower the suction, or we're going to take them off suction. And hopefully we can stop the vomiting, diarrhea, and look at all the drains, what's taking all of the sodium out of the body. We can slow down vomiting and diarrhea with medications. And then we can also give oral or IV sodium to replenish it. Nursing management of fluid volume excess or deficit, either way. So we have too much sodium or not enough. We're going to assessment of patients at risk will be anybody that's NPO, which means nothing by mouth. Patients with drains, we kind of already talked about. NG tubes is going to be draining things away. IVs, does it have sodium in it or not? Post-op vomiting, diarrhea. Anybody with a high fever because they can be dehydrated. Intake and output. The reason I put that down here is because that can actually be a nursing order. It doesn't have to be from a doctor. We can always institute an intake and output if we're anxious about what the patient is putting in and out. Accurate documentation, analysis of labs. Are we looking at the electrolytes? What's the sodium doing? Assess urine amount status always. Less than 30 cc's an hour is basically considered anuria, that they're not voiding. They say there's always a little bit of urine left in the bladder. Specific gravity, and that's how thick or dense the urine is a normal reading is 1.010 to 1.025. It's a ratio of density of one substance, usually water, to another. How dense is that urine? Nursing management. Daily weights. We know if they're retaining fluid or not. Same time of the day, same scale. Are they wearing clothes or aren't they? It's kind of the same the way you weigh yourself. And always document it. Same conditions. Do they have a sheet on the scale? Do they have the chucks? I know when we're weighing the babies in the NICU, we always have to weigh the diaper, if we're putting a diaper on them, the shirt that's on them, and the chucks that they're laying on. If we're putting that all on the scale, we have to weigh that first, because then we're going to put the baby on with it and then deduct that off. That's the true weight. So that's what they're talking about. And then Foley bags. If they do have Foley connected to them, we need to dump the urine out of it. We don't want to weigh that fluid. It's not going to be an accurate weight. Assessment of fluid deficit. Turgor and fluid mobility. Turgor is how hydrated the skin is. And we can look at the skin because we can see the skin and it's outside. A lot of times we'll look at the sternal area. If you basically pull it up, pinch it up, and if it stays there, it should spring right back down. If it stays there, the person's very dehydrated. We can look at the abdomen, the forehead, the forearm, pinch and count in seconds. Abnormal seconds is going to be less than, usually it's 1 or 2. And if it's greater than 3, they're pretty much dehydrated. Oral exam, what does the mucous membrane look like? What's the tongue look like? Can you see lines in the tongue? Fissures is what we call it sometimes. Assessment of fluid excess, accumulation can be first, second, or third degree spacing. Edema, and that's swelling, can be 1, 2, 3, 4 plus weeping. I don't know if I have that in here. Let's see. I thought I did, but maybe not. Nope. Okay, we'll go back. Uh-oh, here. Let's see, where are we? Okay. Edema assessment. This is when you push down on the skin. So you'd push down on the foot or push down on the hand. And if it comes back, if it comes back within 1 second, it's 1 plus. If it comes back in 2 seconds, it's 2 plus. If it comes back in 3 seconds, it's 4 plus. Or is it just weeping, where the fluid is weeping out of the skin? And then, is it cool or is it warm? Okay. So the causes. What causes edema? Increase in what we call capillary hydrostatic pressure. And what is hydrostatic pressure? It increases as a result of venous obstruction or salt and water retention. So hydrostatic pressure increases as a result of venous obstruction or salt water retention. Venous obstruction causes hydrostatic pressure to increase behind the obstruction, pushing fluid from the capillaries into the interstitial spaces. So what is it? What is hydrostatic pressure? It's the outward movement of water from the capillary to the interstitial space. So it goes from the capillary to the interstitial space is hydrostatic pressure. Thrombophlebitis, hepatic obstruction, tight clothing around the extremities, prolonged standing are very common causes of venous obstruction. Congestive heart failure, renal failure, cirrhosis of the liver are also associated with excessive salt and water retention, which cause plasma volume overload, increase in capillary hydrostatic pressure, and edema. Decrease in plasma oncotic pressure. So what's oncotic pressure? It attracts water from the interstitial space back into the capillary. So hydrostatic is where it's taking the water from the capillary to the interstitial space. Oncotic, it's taking water from the interstitial space back into the capillary. Let's see, what do I have about that? Localized is limited to a site of trauma, a sprained finger, cerebral edema, pulmonary edema where the fluid collects just in the space or spaces surrounding the organ. That would be hydrostatic pressure. Generalized edema would be manifested by a more uniform distribution of fluid in the interstitial spaces. Dependent edema is where fluid collects in the gravity-dependent areas of the body. Feet, hands, earlobes, eyelids, it goes everywhere. That's dependent edema. Pitting edema is where there is a pit left after you press on the skin. And here we can look at this diagram. And we've got loss of plasma proteins or decreased production of plasma proteins from some kind of pathology, where the example here is cirrhosis and malnutrition, where we've got decreased capillary oncotic pressure. And again, oncotic pressure attracts water from the interstitial space into the capillary bed. It's decreased, so it's going into the tissue to cause edema. And then loss of proteins the other way, increased in tissue. Oncotic pressure is, again, attracts water from the interstitial space back into the capillary, which is going to cause edema. And you can see it can result in decreased transport of capillary filtered protein, where you have lymph obstruction and decreased absorption of interstitial fluid. Fluid movement into a tissue. Also, we can go up this diagram where you have increased in sodium and water through renal retention, if we've got something wrong with the kidney, so it's not getting rid of the fluid, it's retaining it, that can also lead to swelling. So basically, when you're looking at this diagram, we can have loss of plasma proteins at the top. We can have fluid at the bottom. We can have fluid movement into the tissue. And we can have, on the other side, decreased absorption of interstitial fluid. And with all of these things, depending on if it's in the capillary bed or being pulled into it, we can have swelling. Okay. So edema can come from several sources. And just remember, oncotic attracts water. Okay, nursing interventions, especially with skin care and water. We can have breakdown of the skin is more likely with fluid excess or deficit. We need to assess it more frequently, elevate the extremities, no constricting garments anywhere. Dehydrated skins, we can use creams and oils to try to get them to not have so much dehydration. Neurological assessment, brain cells are extremely vulnerable to sodium and electricity in the sodium pump. Fluid excess and fluid deficit. So either way, with our sodium, hypo or hypernatremia, we have to remember to assess the level of consciousness and consider seizure precautions. Real or relative loss of electrolytes. Real loss of electrolytes are gone from the body. They're just gone. We've got a lack of potassium or lack of sodium. A relative loss means the electrolyte has moved from its usual body compartment. So it's not in the cell, it's in the blood. Treatment will vary depending on whether it's real versus relative. It may be relative according to pH levels or disease. Okay, for the next video, we will talk about potassium.